Thank you. 10 people have already joined. I'm sure lots of more people will kind of join for today's talk. It's my pleasure to introduce my co-chair Jensen to present today on medication errors in children. So this is not renal disease per se, but I think a very interesting topic for all of us working in the BNCH. And just going back to the question about nurses, I mean, really, the aim of these lectures is to make them not necessarily only applicable for doctors. It needs to be an open forum for doctors, nurses, allied health professionals, anybody who's interested to attend, trainee all the way to consulting. So please let people know that these lectures are taking place every Wednesday between 1 and 1:30. Can I ask you all to maybe mute your microphones, and then I'll hand over the microphone to Jensen.
Excellent. Thank you, Frederick. Yeah, so really, this is for anyone who has ever made a medication error. And as you know, the chain starts right at the start to actually the parents getting it. So yes, it's applicable to everyone. Yeah, so how I got interested in medication errors is because a few years ago, when you recognize this young man here. I was in Ward 35 as a registrar in neonates, and middle of the night, I needed to intubate a baby, and then me and the assistant in charge wrote the drugs up, checked the drugs, and then intubated the baby, and then he was fine. But the next morning, I obviously came off shift. Other people came on, but the baby was just very drowsy. And then it was only in the afternoon that when people were checked back the drug card deck, can go and mute, please? Excellent, thank you. I had made a drug error, and I didn't actually find out about it until I came back on shift, and it was really quite devastating. And what had happened was that I prescribed some morphine for intubation, and it's meant to be 100 mics per kilogram times 0.8. So if you work out, it should be 80 micrograms, but on prescription chart that I had written at 3 in the morning, I had prescribed 0.8, and presumably that was given. And that's my lifelong interest in medication errors. And then I was a registrar here. So this used to be the Children's Hospital here before we merged with the General. And then I was on call one night as the registrar, and there used to be Ward 4. I think it was the baby surgical unit. And I was called there at 1 in the morning to look at a baby. And what happened was that this child was on PN, and the nurse who had come on had found that the child had all its lipids over 1 hour. So with TPN, the bag of amino acid and carbohydrates run at about like 50 mils an hour, and the lipid run about 5 mils an hour, or whatever, depending on your size. And then the tubes just got switched around. And then, so I was called to the ward, and then said there was a mix-up. Baby was flushed, miserable, quite tachypneic. We transferred the patient to the neonatal ICU, which was also on site. Was very acidotic and was peeing a lot, and the blood sugar had shot up to 45. But actually, by the time we made the insulin up, it came back down nicely. And then we put a Datex in, and then everyone was quite worried. But actually, the baby was fine the next morning, and I presented the child on the round, and then someone said, "Oh, it's very interesting. It's fat overload syndrome." They went to bed and never heard about it. But then I found out subsequently that every so often we were getting these errors. So the question is, how big is the problem, and what can we do about it? So tenfold errors is a big. We think it's a bigger problem in children, because you can have a big strapping teenager nursed next to a cot with someone a tenth of their size, and it does in adults. It can happen as well, but actually we think it's a problem in children. So this is a Swiss cheese thing. So hopefully this will work. Someone about 20 years said it's a neglected iatrogenic disease in children, and I think this is probably as common as a rare disease. So we did some simulation in a neonatal unit and found that about 1 in 12 drugs had a tenfold error. And interestingly, the more senior you are, the more assertive that you are right. and someone else was wrong. And then no one knows how common it is. There's only been 2 real studies done, and they weren't particularly good. And obviously there's a problem with one of the bias of reporting. If you write micrograms instead of nanograms, the nurse will just hand it back to you to rewrite. And how harmful is it? Well, no one really knows. But there was a study from a poisons unit that looked at a tenfold error referrals, and about 10% had moderate harm or above, and about 1 in 1,000 died, and that's the ones that reported to them. But no one really knows. So what I did about 5 years ago was to look at in GNCH Watt with Sarah Scales, who's one of our foundation doctors at that point, about how much bigger problem it was then. And then we looked at all the data access. So, it needs to be bad enough for someone to actually report it. And we found about 10%, that we had about 41. So it was about 10 a year that was happening. And then it was all sorts of medication. And then people, we prescribed lots of morphine, and opiate was the biggest one. So I thought, well, what about looking more nationally? Could we get a bigger data set? So I wrote to the National Reporting and Learning System. So essentially, every hospital they have to report their errors to upwards. So all your data access get put on the big, every so often gets sent up to this big database. And they do some things with it, but it's all in free text. Different systems have different things. So essentially, it was really hard. So I asked for things like, free text anything with tenfold, the number 10, 100, 1,000, and you get loads. And then poor Sarah, this is with Layla Buckham, one of our other junior doctors. So she had to hand search more, and we again found about we only found 50 cases, and that's just in 1 year. But what this shows is that it happens in every stage of the medication chain. And actually, the other interesting thing was that on quite a few of these happen in people's homes. So it wasn't a problem just in hospital. So it was either the community pharmacy dispensing it wrong, or something happened with the GP prescribing, and then all the parents themselves gave too much. Okay, so after that, what I did, so this is, we thought actually what we need to do is to do a post-spec. You could use a BPSU. The only thing is that it costs £18,000, and you have to find the money yourself. So we went to Wales. Wales is great. So Wales is about the size of the northeast, and they've got this Welsh Paediatric Surveillance Unit, which has been set up for the last 20 years, and they have 100% return rate. And so it's really good. And so they do a similar thing to the BPSU. But the good thing is that it's entirely free. So I did it with David Tuthill, who's a pediatrician there. So the question is, how common are tenfold errors in children, and what happened to them? And then so the electronic card was sent every month. There's 230 pediatricians in Wales, and also we included a pediatric pharmacist as well. So we ran it for the last 2 years. And so we had 100% return rate, and out of that, 50 cases were reported, and 20 actually reached the child, and 30 were near misses. They happened in virtually all hospitals in Wales, from the teaching hospital, which had most of them, to DGHs. And as expected, it's the younger ones that had the problems, but not universally so. And they happen in all areas, probably a bit more overrepresented in the critical care areas and in ED. And it happened in all parts of the medication chain. So a few examples. So, the decimal point wasn't clear. So there were no units in Wales in the last 2 years who had electronic prescribing. And then, so someone wrote wrongly, and then it was checked, and then parents tried to get it in, but it was so much volume that the child started vomiting. And then there were some doses which were actually very hard to give. Yeah, and actually we had quite a few underdoses. And as you see in this graph, most were 10 times, but there were smarting underdoses. So there was a few like antibiotics which were given too low, so there was delay in effective treatment. Most of them were actually enteral medicine, and nearly all the enteral medicines were liquids rather than tablets. And actually, the interesting thing was that there was we can't actually find one medicine apart from a few slightly more with morphine, but morphine is the most common ones. So these are the enteral ones. So the ones I've listed are the ones that actually got to the child. So out of the 50, I think we had something like 40 different medicines. So you can't just work on one medicine to prevent errors. You have to work on all medicines. There were a few infusion errors as well. So we used this kind of American system, which is very good to categorize the errors. So essentially it goes from, error never actually happened to it was prescribed but actually never reached the child, to reaching the child, but they just had to be checked over or kept in for an extra night, had more blood tests, to death. So these were the outcome of the 50 errors. So really, of the 20 that reached the child, 5 came to harm, and the 1 actually went into ICU. Actually, most children, even when they had it, did fine. So these are the headlines, really. So at least 1 in 4,000 admission had a near miss. And then about 1 in 10,000 admissions reached the child. So if you extrapolated this to our hospital, we would probably get quite similar values, and the harm occurring 1 in 4 that reached the child. So what are the human factor themes? So, the ones where you got mixed up between like grams and milligrams, none actually reached the patient, because if you think about it, it's actually very hard to give, you're meant to prescribe 1 ml to give a liter of fluid. It's just like not possible. There was the leading zero error was the one that I made, where you get confused at 0.1 and 0.01 and 0.001. And there were a few doses that were far too small to be measured. So a child, actually, you prescribe that, but it surely can't be that low. It'll just give you 1 ml. Quite a few said they were interrupted, and then some people actually miscalculated. So they were meant to times it by how heavy the child was and didn't, or they did, and so on. There were a couple where there were reconciliation errors. So a patient would come in the middle of the night. There were no notes, or notes weren't or there was no list of medication, and the parents said, he's meant to be on 3 mils of X. And then the poor junior doctor, who knows that they're not meant to prescribe in mils but milligrams, tried to back calculate and then got it wrong. And then there was, interestingly, there's a couple of patients where the specialist either phone, or they were on a phone call, or they came to the ward, muttered something, left, and said, do this. When they went to make it up or prescribe it, it's not quite right. Well, they're specialists, they must be right. There's something about psychological safety in challenging someone, or calling our cardiologist back at 3 a.m. and go, are you sure you want us to prescribe X? There were a few protective factors that stopped the error going through. So, for example, parents who were giving chronic medication kind of said, no, that's too much, or they were giving themselves and it was prescribed wrong. And the pharmacist said, that's 10 times too much, but parents had been given the right dose. Actually, we had one recently where the parents were giving the right dose, but they came into hospital. We took that control back away from the family, and because the letters were wrong, actually gave the wrong dose and had a big bleed in theatre. protective practice were having pharmacists, the fact that if the volume is too large, it may not be right. And also there were, in resuscitation, you always give the same dose, and even though you wrote it wrong. So we're near the end. So one of the question is, we've got a fancy electronic medication system. Can that help? And the answer is probably not, and probably yes. So in all the studies, they show that it will reduce errors, but usually these are legibility and the fact that you're forced to put a weight in. However, none of the meta-analysis can show a reduction in harm with electronic system. Unfortunately, in the UK, there's no standardized system, so every hospital's doing their own thing and going to buy different systems. There's a recent study where they tried to get hospitals with electronic prescribing, to actually simulate errors, and over 90% of errors got through. So what might help nationally? So this is what we're trying to work on, something about the systems, human factors. The NPPG and the BNFC has been, actually the BNFC has only been around for about, I think 1999 was when the Green Medicines for Children book first came. So before then, that was totally random. So there is some efforts on trying to standardize things, and I'm trying to get a grant for a BPSU study to try and look into this a bit more. So lastly, your take-home messages. What could we do today here? So I think we should prescribe less. Many patients are on lots of polypharmacy. Do they really need this omeprazole just because, just in case? Yes, some people, that's absolutely true, but for many, do they really need it? We shouldn't disturb anyone prescribing or dispensing medicine. We need to minimize the use of liquids, because it's very hard to give someone 10 tablets. So try to convert them to tablets as quickly as possible. I think now we've got our e-notes. We should use written communications more. With the chronic medicines, parents are a great source, and I think that's really important. And in the background, there's always continuous improvement happening in prescribing, and we need to make really good use of our very precious pharmacists. So I think that's it. So that's all I have to say. Any questions?
All right. If you have any questions, either if I can see you, if you can show your hand, that'd be good. So Jeff is going to start off. Okay. Do you want to unmute, Jeff, and to ask a question?
Yeah. So Jensen, one of the things you said about chronic medications, and a lot of our oncology patients are with us for a very long time. When you go into eRecord for the same drug, some patients have 6 or 7 kind of entries coming up in their medications list about that drug. And particularly if dosages change, it still is coming up. And also, because controlled medicines are being done on paper, the controlled medicines, unless you actually go in and put them in, which is very clunky, aren't going in. And I think that's a real risk for these patients. eRecord is a massive risk.
Yes. As I said, every hospital in the NHS is sourcing its own system, and it's a huge problem nationally. And there hasn't been any steer from above and say, why don't we all buy or make a great system? There was this £10 billion e-learning NHS e-system, but that all fell apart. So yes, hospitals have to buy what they feel, is within their budget, etc. But yeah, so it is a problem.
I was going to say, I don't know if share my screen will work, but if it does, it should hopefully show you.
I'm sure you're absolutely right. It's not a great system.
No, it's a risky system as it stands, I would say.
Yeah, I mean, there's continuous work being done, but yeah, I mean, in our hospital, we've got 2 or 3 really good pharmacists who are the only regular e-prescribing pharmacists, i.e., they're the ones who are sorting the system out, and it's a real and their workload is huge.
And they've probably saved numerous errors from ever getting anywhere. But I think unless we flag up for e-record, unless we flag up that this is a safety issue, we will never get any changes made. And as the safety lead, that's why I'm flagging this up to you.
Yes.
Enjoy.
Thanks, Jeff. Okay, next question is for Chris.
Unmute. We did, so many of these things have been done repeatedly. There was a previous drug audit that identified, opiates as a common cause of 10 times error. And one of the things is that we were being asked to use adult vials on the pediatric ward. And there was a kind of concept, I don't know, maybe one of the pharmacists can chip in here, of getting rid of, because what would happen is someone do a calculation, they came up with a dose of 0.001, which is impossible to give, and then they thought, I must have calculated it wrong, so add a couple of zeros. Oh no, that looks better. So one of the things was to remove the reliance that we have on adult vials.
I'm not quite sure what our own system is. However, every fix may have unintended consequences.
Yeah.
The important thing is that if anyone ever writes a guideline and they never do the job, then they should not do the guideline. So we've seen many diktats from on high in the past. So I think the good thing about quality improvement is a frame of mind and say, actually, if we're going to change something, we have to see what the consequence of that is and keep looking at it and not just publish a guideline and walk away. Anyone else?
Yes, I've got a question. It's Christine Rawlings from the Peds Oncology team. I just wanted to ask about the updating of medication kind of prescribing for pediatric patients in different wards. So, for instance, for example, we use Tazocin very regularly for our patients, and the options that we have are, set doses, QDS or TDS or BD, and not the per kg 6-hourly dosing that we use all the time on our protocol. But I just wanted, is this updating of commonly used medication standard doses, is that occurring, or is that able to occur in an ongoing way through e-record?
Yeah, well, I mean, I think if there's any changes that you want to make, the best thing to do is to speak to the pharmacist in your area, and they may be able to take this upwards. I mean, there are things that technically can't be done from a system, but there are quite simple fixes. And then also, the other thing is that any changes will apply for the whole trust. So sometimes that needs to be borne in mind as well.
Karen, we can see your video on. Are you wanting to ask a question?
I'll just unmute. I was just going to respond to Dr. O'Brien's query about the size of the vials. Often we're stuck with whatever the manufacturer produces, and there's only a few licensed pieces of vials.
Yeah.
I don't know if you can hear me okay, but you can get a pediatric gentamicin vial, but there's not a lot of options out there, unfortunately.
Yeah, so we get the point. So even though we want to have an ideally pediatric vials, they don't always exist.
No.
Yeah. Okay, thank you. Sunil, do you want to ask a question? Yes.
Yes. Thank you, Ethan, for a good talk. There's probably a system for this already. When repeated error identified the drug, is there a system where you could send out an email once just a single PowerPoint slide summarizing what the mistake was, what the learning was, to all the medical staff, including trainees and consultants. I'm not sure if that's already happening. That's a good thing.
Yeah, well, I mean, I think what we saw in Wales is that because it was so many drugs involved, I mean, it was virtually a different drug combination for every tenfold error, that actually it's not the drug itself, it's the fact of our medication system on children. Anyone else?
We see no hands, so I think we're going to leave it there for today. Thank you all for your attendance, and please come and listen again next Wednesday at 1:00. Thank you so much for your attendance. Bye-bye.
Thank you.
Thank you. Thanks. Bye.